All right, welcome everyone to another episode of a surgical Saturday or any day that we're airing this. We're coming to you from Colorado Surgical Institute. And today we have Dr. Daniel Briskie as usual, but we also have the amazing Dr. Corey Raymond from the Academy of Modern Implant Dentistry in Philly. Is it up by the King of Prussia more than Philly?
Yeah, if you know the Philly area, right near the mall, great shopping, let me tell you.
Yeah, and if you guys haven't had a chance to hear Corey speak, one of the more engaging speakers. The first time I heard you speak, you made us boo you off the stage, and I
Okay.
love that. And so that was a really cool moment to kind of see you on the stage for the first time. But Corey, can you give us just a quick? I know you've done a lot in your career, but just like the quick cliff notes or a bird's eye view of kind of what you do now.
Yeah, so I've been involved in implant education since 2017. It's been kind of fun to see the digital evolution over the last, 7 years. So we've already tried to stay, like, on the forefront of that. We have private practice in Philly where we do, we turned into almost an art center, which I didn't plan on. So it's been good though. So we've been able to stay, ahead with 3D printing, digital design. And now we're just trying to get this out to as many dentists as we can to try to help improve their practice, improve their patient experience. And, it's been fun running across guys like you. We get to know each other. And I think it's fun to see the camaraderie that's starting to finally be built, in the education space. So, hopefully we keep this going.
Yeah, well, amen to that. So today we're going to talk about guided surgery. I think Dr. Brisky is going to take more of the stance of free-handed, or at least support that argument more. Corey, obviously, a wealth of knowledge on the guided side. But where should we start? I mean, do you want to start with single implants and just talk about singles before we talk about full arch and talk about the benefits of guided versus freehand? So, Corey, what are your thoughts? If someone's placing a single implant in their practice, and they said, "Hey, I'd rather do it, freehand," and then you're like, "Hey, here's the reasons why you need to do a guided." And what would you say to someone like that?
Yeah. I mean, I get this question all the time. So I think, there's plenty of people with free hand chops out there. It's not even a question of surgical skill, I think, half the time. I think getting into guided really opens up more interesting avenues in the prosthetic workflows. I'm going to say it really shines in some of these anterior cases where we're looking to immediately load. Now we can have prefabricated temps with ideal contours. We're generating tissue architecture in a much more predictable way. Um, and then for, let's say, I hate when people want to use it for a crutch for surgery. So even when I lecture on it, I tell people we're doing surgery guided, we're still flapping, we're still saving keratinized tissue. The fundamentals of surgery don't change. But I do think for someone who is just maybe a little bit earlier in their surgical career, it does open up the opportunity if you do it the right way, I think, to get an eye for, okay, this is the correct prosthetic position. And it starts thinking about, from a crown down approach, they can start seeing, all right, this is where this drill should be going. This is where this, parallel pin should be emerging. And I know, like, when I first started, it was difficult for me personally to say, like, in these anterior cases, I was just like everyone else. I wanted to cheat a little too far facial. And then I would do guided case. I'd be like, oh, that pin, all right, this is where it should be coming through. And I think, if you give those dentists the confidence to be able to deliver this, then it really allows them to expand that surgical skill set. But I think I'm going to maybe be a little mean here. I think it goes back, though, the way guided was marketed in the beginning, where it was anyone can do it. It's easy, less invasive, simple. The fundamentals, I don't think, should be changing here. And if you understand, well, the guided principles, as far as, it's developed by engineers, not by dentists. There's error that can happen. It makes you have a better appreciation, I think, for the limitations in it and where it can also shine.
So, Dr. Brisky, when it comes to single implants only, what's your take on freehand versus guided?
So, I think a lot
Yeah.
to engage our course or like Dr. Corey's course here. You get kind of two camps early on. It's kind of interesting how docs think. They come in like, all right, I need guides to help me place these implants. It's the cool, sexy way to do it, right? Then you have other docs, like, I just want to drill a hole. The answer I think is a little bit in between it. Oh, at CSI, my personal recommendation. I've been doing courses since, gosh, 3 years now. We've celebrated our anniversary. And I always recommend docs for their first 25 implants to struggle as much as humanly possible by drilling your own holes. Then I actually recommend them to do a pilot hold after that. And the reason is what Corey Raymond did allude to, which is understanding a 3D roadmap of the bone in your brain, because you don't really know where you are. Like you may think you're buccal, but you're really lingual, or vice versa. You don't know really where you are in the middle of the bone. So, but to fully understand density, which is the biggest thing that I really try to get new docs into, is understanding D1 through D4. Like what's the case of D1, what's the case through D4. Uh, and I my biggest complaint with guides is it's really hard to tell D1 through D4. So I see a lot of docs saying, well, I got a spinner because the bone was D4, but the bone was actually D2. And you're like, no, the bone wasn't soft. You just don't understand what the bone is like because you're not drilling and understanding the bone density or the feel of the bone. Like you got to become one with the bone a little bit to almost understand how to use a guide, I would say. So that's actually what I did. I struggled through my first 25. I got a pilot hole guide. I started making them off of Blue Sky Bio. And then once I felt comfortable with the 3D roadmap in my brain, I threw it in the trash.
So let's pull on the thread of being able to sense density when using a guide. Corey, do you think it's true that you can't sense the density in the bone with using a guide, or like you can have an increase in the amount of spinners, or how do you kind of like circumnavigate uh, that thought process?
No, actually, I agree completely. So one of my biggest things when people are doing guides, it's gotten to be very predictable. So they almost move too quick. And then one, I worry about irrigation getting down to the site for some of these new beginners because it's just so fast. But then, yeah, they lose that ability to see, all right, how much resistance am I really having? Because you're not worried about, sinking too deep as far as depth goes. You're not, you're still controlling mesial distal, but we're controlling within like a tenth of a millimeter instead of having free reign over the site. So I do see a lot of beginners that don't really develop that tactile feel. And that makes me nervous then when you go start to get to these more advanced cases. They get more comfortable. And now it's like, all right, how do I control this osteotomy to be able to ensure that I get the torque that I need to get when I start getting into these immediately load cases? And I think it's funny what you said. We do these courses. I'll get probably half the people. They're like, I'm going to do everything guided forever. I'm like, that's a horrible idea. But one, like, what happens when you drop it on the floor and you break it, right? Doesn't fit. I think that everyone should at least learn how to design their own guides, whether it's at least single units, because it gives you a better appreciation for maybe, how it's done and when to use it. And I don't know if I should admit this, but like I used to say, do your first 30 freehand. And then people kept bringing it up, bringing it up. So we do these courses. I'll pick the patients beforehand where guided would be very difficult. I'll be like, all right, number 30, small opening. All right, you want to do guided? Here you go. Right. And then they'll be like, well, I can't get it in there. I'm like, exactly. Right. So understanding when to use it to be able to get that is a huge thing.
Okay, I love that answer. And I love not sticking to the whole guided has to be right in all situations, because that's the beauty of the podcast, right? It's like we can be agnostic to different situations and understand, like, yeah, like a range of motion issue with patients who have limited opening, a guide may not be advantageous in the back of the mouth. So I'm glad you brought that up.
Well, it's also like a lot of docs who just like only guide surgery. They're all about minimally invasive. So when I hear a lot of docs talk about guide, like there's a guy, you see these pictures and they're doing, they punch through the KG, they're not flapping, they're not actually seeing where the implant is. So I think it's very important. Like if you do choose to use one for, I think you got to flap that thing. I do not approve of just completely let's implant placement and punching away in that keratized tissue in those circumstances.
Yeah, I'll just caveat that comment with, like, if you got a mile and a half of bone and a mile and a half of kg, punch away and don't flap, right? Are you
Yeah.
guys cool with that, or Corey? Are you just like, hey man, flap everything because it's a concept that we want to
Uh,
really have people understand.
I'll give you, if we got 12 millimeter wide ridge thickness and an 18 millimeter band of keratinized tissue, if you really want to punch that, I'll let you get away with that one.
Okay.
I think the other cool thing with it is let's take it maybe away from the clinical side, where patient experience, though, is also a fascinating thing to me. Where if I have a patient come in for a consult that had an implant put in like 5, 10 years ago, and they tell, and they all want to tell you about their experience, right? Oh my God, it was horrible. I was in the chair for 2 hours, right? And then this, and I was like, I try to do those guided. One, from the consult perspective, it allows me to sell one, I mean, maybe not cutting edge anymore, but to them, it's very cutting edge. And then when they're in the chair for less time and we get this, truly ideal position, they'll all be like, from the patient perspective, like, why doesn't everyone do this? Right. So I think you can use it also as a great business tool to help maybe close a couple more cases. But then I call it the snowball effect. This patient is like, this is way better than it was 5, 10 years ago. Then they tell their friend who tells their friend. And I've been amazed how many patients I've gotten just because we do all this design and 3D printing for guides in house. It definitely has actually impacted the business from a number standpoint as well.
Okay. Yeah. That's a very good point. Like perception of public opinion. And even though like, you know, 3D printing and stuff is more routine than it was maybe in 2017, right? And people like yourself have pioneered it. At the same time, patients in their eyes, like they'll talk about you at the gas station, they'll talk about you at the mechanic, because like you have the technology. So that's cool. I guess the one thing I want to talk about also is prosthetics. I was at a lecture recently and they said even if the implant is slightly a couple of degrees off, when you go and screw retain, it puts an off axis load on the screw, because your crown has to go in parallel. And if it's not, then there's pressure exerted into the implant or into the prosthetic screw. Have you guys noticed that? Like, hey, that's why guided is more beneficial in single implants because of when you get to the prosthetics, then you don't have load into your screw? Or is that just something that I heard for someone who had to come up with 17 different reasons why guided is better on singles? And that was one of the points because it did make a lot of sense when I heard it.
Rusty, you want to start this one off before we make some people mad? Probably. Go.
So, yes, there is definitely some truth to that, right? But a lot of the time with seating like prosthetics or single teeth, it's like the parallelism of the two adjacent teeth more than it is about screwing the implant in at the restorative level. Obviously, you can't place it, 30 degrees off and expect to get a retained implant, right? So there's some basic fundamentals of surgery. So yes, there is some truth to that at a very nerdy level, but I think I think if you have good foundations of surgical skills, I just don't see how that's a major issue.
Okay. And Corey?
So my question I always ask, right? Look, all right. So we look at like a finite element analysis and we say, okay, there's a little more stress in this screw over X number of years, right? What's the clinical significance of that? I wonder, right? So, I mean, and I know this is anecdotal because it's just patients I'm seeing. I see patients from 20 years ago. They've got the same screwed in abutment that's 20 degrees off angled, and it's been functioning fine with no issue. Now, I think in this day and age, we should probably shoot for a little bit better than that. But I can't tell you with new connections, cold welding the abutment to the implant. I can't think of a single unit restoration that I've had loosen in the last 4 to 5 years offhand. Now we are seeing some of those older connections and maybe, 10 years later, we got to go back in, put an access hole in. But I just don't personally see that in the clinical practice day to day.
Like a trilobe, I actually had a case this last year where there are multiple implants that actually had to remove one to do two adjacent units. And the every time I would go in to remove the temp abutment, it was always loose. So I actually finally just told the patient, like, hey, I'd rather just replace this implant because it's right next to my really nice implant. Right. So I had a deep conical connection next to a trilobe. And I'm like terrified that that trilobe connection is going to ruin my adjacent, very nice neodent implant. Right?
Did you
So
last it out?
it was, of course, I think, imagine trilobe at 20 degrees off angle, right? The problem, of course it is.
Yeah, and I know. So to me, like when I lecture, I say to me, there's three positions for implants. There's ideal, there's restorable, there's unrestorable. And I probably will get some flack for this, but I still don't see anything wrong with a properly designed custom abutment, bringing the cement line up, maybe only a half mil subgingival, where I think that's almost been underutilized now. because everyone is so like, we have to do screw retained. And don't get me wrong, there's the huge advantages to it, but I still think there's certain situations where properly designed custom abutment with a cement and retained crown may be the better option for the long term and in certain situations.
Okay. I appreciate you guys taking the tangent away from guided versus freehand to talk about prosthetics. So, but all really, really good points. If you guys don't have anything else you want to mention on singles, you guys want to hop into like overdentures and just talk strictly overdentures. No, like all on X or all on four or fixed full arch stuff, but just specifically overdentures. Dr. Briskie, what's your take on guided versus freehand in that situation?
So if you're doing guided with overdentures, right? A lot of times you're still gonna need like a bone channel, right? You're gonna need the bone reduction. You're also gonna need the implant position. Um, those do work, but I've had just personally for myself, and I've had a lot of the bone channel guides, especially like not fit very intimately around those areas, and it was very hard to tell if something was seating or not. Right for the guide portion, I felt like it was not seating about 20% of the time. And it left me a lot of time just wondering if it was all the way in or if it wasn't, and what my wag factor would be from that drill. So how far away am I from ideal? So personally, for me, I would rather just make a big ass flap, right, and place some big implants and close it of it, and that's my preference.
Okay. And then well, actually, Corey, I'll volley that back to you, and then I have a couple of questions for what Dan just said.
I think if used correctly, it can be a great tool. Um, Even if we're talking overdentures, there still needs to be enough restorative space, for housing, if we're going to do metal frameworks. I think I actually, when I lecture, I'll say, like, I don't think overdentures are given enough respect because I talk to these dentists. They're like, it's overdenture. I'll just slam screws in. Well, we'll be on our way. Um, Now, guided on maxilla can be a good option. So, I mean, in my practice, I don't know what you guys see. If we're talking overdentures, I'd say actually most of my overdenture patients start fully edentulous when they come in. It's like if full arch fixed seems to be terminal dentition. So now, if we're talking guided surgery on fully edentulous, we're starting with some sort of soft tissue borne guide. So maxilla, not bad, right? We can index off the palate. We have a little bit more surface area that can be fairly predictable. It's again now understanding the limitations of guided to get the result you want. So if we're talking about, let's say most mandibles, or especially a slightly to severely atrophic mandible, to me, I don't even think about guided. It's like, how are you going to index the first guide to make your points? Where if I can take your well-fitting denture and move it side to side and I can't get a definitive seat, guided goes completely off the table. However, I think, to Dr. Briskie's point where it was, the bone guides can have a lot of slop. I will say, luckily, within, I'd say, the last year and a half now, with AI segmentation getting a little bit better or a lot better than I could ever do myself, we are seeing a much more intimate fit of that bone guide to the jaw, which is nice because it does take a little bit of that guesswork away. But, anytime we have multiple pieces now being stacked on each other, there is a little bit more inherent air in there. And if we're talking about these overdenture cases where they're already maybe a little bit narrow or atrophic, that is really where guide only shines if we understand the principles of guide fabrication.
Okay. And so let's say you're in a situation where you're doing an overdenture and you can't use a guide, and then we're moving forward to like the parallelism component of it. Dr. Briskie, in a freehand approach, how do you ensure that your implants are going to be parallel? Because the guide really truly helps a lot in parallelism for your implants, but how would you control that in an overdenture case?
So every case that I do always gets planned on a CT, right? So I feel like I'm already going into I'll use for me, I love tech software because I can easily just throw some implants on the CT. I can see the path of where it's leaving, right? So for me going in, I already know what size implants I'm placing and how much reduction. So I'll do a general ballpark. And early on in this progress with overdentures, I used to actually make a bone reduction guide, and that was it. I'd use the bone reduction portion and I'd throw it away because I've replaced the rest by itself. I think the hardest part for doctors to get down is actually just the prosthetic space removals. You have to remove average 4 millimeters of bone. I'd say 90% of cases. So before knowing that, I would just place them implants. And you see these cases come in all the time where you have this big wavy interior mandible, and the implants are placed really high up. So no bone reduction was down there, right? So you get them little teeth and a little denture that keeps breaking on each other. But for me, once you understand how much bone to remove, right? I think paralleling the implants, I I used to start by drilling a pilot hole with my 1.5 millimeter lance, then a two. So I'd do one in the anterior. So let's say in most cases, your implant positions are first molar and lateral incisor, right? That's where we're going for. So you go 19, 23, 26, 30. I would actually drill 19 and then across the way, I would drill 26. I'd make those two parallel. Then I would drill the other two. I'd drill 23 and 30, make those parallel with each other. So that's how I did it. I would do cross arch. So I do 19 and 26, and I would place 26 equal to the other one and make that one equal to the other. So I'd work a little bit backwards, almost diagonally. That's how I used to do those cases.
Do you feel like that's possible and for like the general mass population of dentists to, because your surgical skills are quite like refined. So do you think that that's something that, most people could, aspire to get to, is the parallelism with that? Or do you think they'd have to potentially have a crutch of custom locators and just different things in their armamentarium for later down the road?
I think that's why struggling through some cases does help. Right? And then use the guide along your journey. That's what I like doing because I feel like the guide will be there to help you for my view until you're ready to throw it away. Yeah, I guess would be my best answer. But where it's really helpful is I really think reduction is very helpful.
I
Yeah.
would agree with what you said too at the beginning, you brought up pilot guide only. If I was doing most of these overdenture cases, I would probably do pilot guide. And that way, one, if the guide is off, because we're starting at tissue level, at least you haven't obliterated this entire area of the jaw. So you can still go in and check. But if everything fits as expected, now you could get these extremely parallel, let side cutting burrs just basically finish you off.
Okay. And then Corey, what's your take on like the custom locators like companies like True Abutment and stuff are coming out with to help in the event that implants are like everywhere? Now you can just design parallelism. Have you ever used them before? Probably not because you have, your systems in place, but what are your thoughts on them? Regardless.
I'm not sure. So it's in theory a great idea, I think. My question is, have we looked really into the long term of what happens on, let's say, an off-angled implant with a angled locator? I haven't seen anything about it yet. This is where also, if you want me to get on like my soapbox, I think the bar overdenture is the most underutilized treatment in all of full arch dentistry because now we can correct for those misangulations with a multi-unit on a bar and then tap them in, which I think for a lot of these cases that are even going to fixed, and I'm guilty of it, where I'm like, this is a better removable case, but the patient will not accept taking their teeth out every night. That's where I actually would like to go. But I think, I mean, there's cases where, I mean, you're going to need it. It's just the nature of the beast at this point. Whether it's old implants that, for health reasons now we can't replace, uh, cases where bone morphology is only going to allow for so much. I would still rather get his passive slash parallel fit on the abutment locator interface than I would by trying to do off angle correction in the liner itself personally. So I could see the advantage.
Okay.
Yeah, I feel like these custom locators are just giving a lot of dentists a reason to place uh, mal-angled implants and try to get out of the one-off situations. I feel like if you have a good game plan going into a surgery, I feel like you can execute that game plan and use the correct product, right?
So I haven't used them. So I don't know, like, could you, like, what if you now, the only thing I could see being somewhat of an advantage is to gain just a little bit more spread if we're getting that long-term health going direct to abutment on an overdenture or 30 degrees. That could be nice because if you're seeing these pneumatized sinuses, atrophic cases, now instead of trying to fit 4 towards the front if they can't afford the bar, it could open up some other treatment modalities, though.
Yeah, and I can definitely see the logic in terms of like the distoangular implants. Um, Pulling on that thread though, like what's your take on overdentures in the maxilla versus fixed full arch? And I have a handful of overdentures I've done in the maxilla over time, and I have bone loss. And I have some that are absolutely great, and I have some where it's like everything was fine. The patient did everything they're supposed to do. Maybe there's some bruxism, maybe there's some parafunctional habits, but we have bone loss on implants nonetheless. What's your take, Corey, first on overdentures in the maxilla?
Again, in an ideal world, I think we go to bar. If we're going to do some sort of overdenture, let's get a rigid, splinted, almost fixed biomechanically from an implant perspective. But I try to live somewhat in the real world where I understand that a lot of these patients have saved up enough just to be able to afford 4 implants and an overdenture. Because if you had we know the bar is almost more expensive than the fixed prosthetic is. Um, I will say I try to, if I do an overdenture in the maxilla, I try to follow more of the fundamentals of fixed surgery where I do shoot for bicortical stabilization on these implants. Even though, so I'm trying not to get like an 8 in or something like that. Let's treat the surgery like we would something that needs to be more robust. And if we're going direct to implant with the locator, every denture I do on the upper gets a cast metal reinforced framework to it, just trying to make everything as rigid as possible, kind of in that apparatus as a whole. But to your point, I will say the most bone loss I've seen as in an overall subset of treatment modalities is that maxillary denture, overdenture. But I mean, the question I'm always asking is like, are we doing more harm than good? I think for most situations, it's still an improvement in life for these patients as far as function goes.
Yeah, it's a great answer. Dr. Brisky, do you have anything to add to the overdenture in the maxilla like conversation?
So I would recommend an overdenture in a few scenarios on the tongue. I would recommend it if they have enough bone for when it does fail, I can do an all X, right? Because we know it will eventually. I really strongly believe that. So if I look at a case and they have 6.5 millimeters of bone, I'm like, oh, like this is it's one and only, right? You get one chance to get a good surgery before this patient does becomes a zygoma case. Right. So in those cases, I tell them you have two options. Either we do it correctly and we do fix, or we do a vestigioplasty and a denture, right? In those cases. But if they have a lot of bone, we can place implants first molar site, right? And a lateral site, again, for the max. And I'm placing 10 to 13 millimeter implants. I think that's fine. I'm okay with that. But obviously, it's something that I would probably warn the patient that this may not be forever. This could be something that lasts you 5 to 8 years. Or at that point, you do a surgery that's upgradable, right? Or you do more of an all on X style. You do put multi units on. So you put your 13 or 16 millimeter implants over the sinus. You put your 11 and a half to 13 anterior mandible or anterior maxilla. And then you do multi units, the snap and locators on top of it. Because if you have bicortical stabilization and decent bone, like a D2 bone on the top, I'm okay with the spin, but still I would warn the patient that someday you may have to have another surgery.
Okay. Yeah, I like the option and the ability to upgrade. Corey, are you doing any of that like upgradable type of stuff where, hey, we'll do the surgery like it's an all on X, give you the overdenture now, and then when finances permit, upgrade you, or have you found another workaround or philosophy on that?
I'm going to sound like a curmudgeon again here. All right. I so in certain situations, I think you can make it work. My biggest issue, like when I was out of school starting to learn this, every lecture I'd go to, they always talked about this upgrade option, upgrade. And then I was like really confused because the arch for a fixed prosthetic looks very different than the arch that we should be seeing for an overdenture, right? So if we're talking fixed, we're implant supported, we need very cleansable intaglio. We should be sculpting that tissue with the temporary. And now taking them from that overdenture option where we should be ridge lapping, we need tissue support. I think that's another issue for these atrophic cases I see failing with overdenture. They're utilizing, you know, they're utilizing an abutment that's 15 millimeters from the occlusal table, and these aren't rigid connections, right? So it makes me nervous to try to offer people that option. I would honestly, personally, like I would rather work with you on price and payment plans that you're comfortable with than trying to say, all right, I'm going to do this surgery now that maybe you'll look like fixed in 7 years if you ever come up with the money. And then I got to figure out how to retrofit and resculpt. I'm just personally not a fan of that option.
Okay. Yeah, all really, really valid points on why you don't do it. And then last question, I'm sure I know the answer, but do any of you guys or have any of you guys ever immediately loaded an overdenture case? Okay, this is a good topic. We got Dr. Briskie shaking his head yes, and we got Dr. Corey saying no. So Dr. Briskie first, yeah, tell us about loading the overdenture.
So I have done a few cases just like that, but I don't do it anymore.
Okay.
And
But the head, you had so much. I was like, all right, this is going to be good. You're like, no, not again.
yeah, but I decided not to. There's a few lectures out there for you talking this up as a really good option for patients. I just don't believe it anymore. Unfortunately, I think maybe it could be a good thing at a point, but I think the risk is pretty high. I'm actually at the point where if it's an overdenture case, bearing everything and I'm suturing over the top of it, I don't even allow healing abutments to be in an overdenture case. And I don't even allow that in any of our education courses. So when we do courses and we're placing a single implant through overdentures, we're suturing over the top. I need the biology to become stable. There's always a way that a patient can chew on the healing abutments or have a malfitting denture where they're just not doing it. Even if you do your best job at removing the acrylic right over the top of it, they still do. And when you saw it reline, it still hits the healing abutment in the wrong angle. I think getting long enough implants in the bone, like 13 implants, and needing the implants to be 50 Newton centimeters or more in terms of your force, can you have a successful immediate loaded overdenture case? Yeah, you can, but I've had so many I've had some random implants fail throughout the process that I just wouldn't recommend it, and it makes me paranoid or sleepless. So I'd rather do an immediately loaded fixed temporary fixed arch than I would do an overdenture, right? So like what Corey said, yeah, help the patient a little bit financially. Hey, maybe if you let me use your marketing video, they'll give you another 2 grand off, and then you just saved yourself a bunch of sleep. That's
Yeah,
I
Corey.
crazy
anything on
thing is
the-
now with technology, I know we're going to get into fix, but with technology and fix now with design, 3D printing, well, if you take in chair time into account, I don't know how much I'm really saving by doing overdenture anymore, which
yeah.
has really been a paradigm shift. But I will say I'm going to agree with almost everything you just said. Uh, So it makes me nervous if we think about full arch fix when they bite function, all that force is getting transmitted through that apparatus right as a whole. Where now we're talking about overdenture, they got to take it out to clean, probably 2, 3 times a day. If we're loading these, every implant's taking the same amount of force now on that insertion and removal. And then it was interesting because the only cases I was really seeing bone loss, let's call it mildly frequently, was overdenture cases that we were putting on low profile healing abutment. And we were seeing like kind of like dive back what I was expecting to see like 10 years connections. So we started doing every implant we did for overdenture was actually buried 0.75 millimeters subcrestal with a flat cover screw. That way the bone around it was protecting that compressive force a little bit. And that seemed to get rid of that issue. And ever since that day, I was like, every overdenture case gets buried, sutured, and then uncovered when it's time to start final fabrication.
Okay. Love it. And then, yeah, for everyone listening, that's absolutely the most predictable way to do it. It's better not to play with fire and have your implants fail because you loaded the overdenture, even though some people are saying it. At least all three of us agree on that one comment.
That's
So
hard to find too. That's hard to find in this world.
It is. It is. You got, 10 dentists and 12 opinions. So let's pivot into full arch, I guess let's pass it off to Corey, man. Like you're in the guided world. I started my full arch journey and I was doing the row chrome stackable guides. I've gone to I follow Danny Dominguez's stuff and is it Corey Glenn
Yeah,
as
blue.
well? Yeah, yeah. So um and then obviously, Corey, like you're in this digital space and you're like like so knowledgeable about all things guided. What's your take on guided full arch? Because I know this is a very divisive topic. And there's two very clear camps, and then there's some people who live in both worlds. So what's your take?
I like to call myself Switzerland when we talk about this subject, to be fair. But I think guided full arch fixed is still a great option for a lot of dentists. One, kind of going back to what we talked about before, where bone reduction, if we're needing to do FP3, needs to be even more significant. If you were to give dentists one piece, give them a bone reduction guide.
Mm.
One, it's ensuring that they have the adequate thickness for material strength. Two, they know that we're getting proper emergent positions for our abutments. Like, I think that's the biggest thing. And then three, we know we're hiding that transition line for aesthetics in these cases. Now I think it's interesting, we're all kind of on the forefront of technology, I think we've all been using photogrammetry now for what, 3 years, probably. Like, it's been cool to see this evolution where, we've been lucky where we have the volume of patients where we're able to incorporate this kind of technology. But for I think too, for the dentist starting out, or I would say your average dentist who's doing 2, 3 arches a month, going into guided opens up more prosthetic avenues than you would have when you can't justify buying expensive capital equipment for 1 or 2 cases a month. Uh, I think that's what really ties it together in a very interesting way, and really is the almost the biggest advantage for full arch guided at this point.
That's interesting you would say that, you know, because the general like, thought process out there is if you're using guides, you are burning a lot of money. And so it's interesting to hear the thought process of, well, you're not making the capital investment, you're saving on obviously there's all the tax basis costs and all the, tax stuff that we can talk about. But at the same time, I've never heard someone say, hey, you're going to save money by going to a lab and have stackable guides or just guides in general.
There's always an inflection point, right? Like, I tell dentists personally, like, I think my number would be for me to make that investment where the staff is comfortable with it, we're using it on a predictable basis. I would probably be like 5 to 6 arches a month every month. And then I would say, all right, it's time for us to incorporate 3D printing. It's time to start looking at photogrammetry options. Like, absolutely. But I think for those dentists who are just starting out, I wouldn't want to make, you know, 80,000 in capital equipment investment. One, if I didn't even know really how to use it. I think this is what you guys are doing a really great job at in Colorado. Everyone I've talked to that's gone to your courses, they're like, well, I can actually implement what I learned there. And that's a big miss. That's also a piece that I also have an issue with where people can sell this equipment to these dentists, but unless you know how to actually utilize it and train the staff up, I don't really see what the huge advantage can be until you're able to actually implement it.
Yeah. Well, Dr. Brisky, someone who's newish to the game, because that's the avatar we're talking about right now. Would you guide them to guided or freehand? And kind of what would be your advice and the reasons why on that?
I just think back on a lot of my experiences, like with this temptation of like the back and forth and how do I learn the fastest. I still, so every patient that has a fixed arch surgery needs to leave with teeth. Every single patient needs to. They're going to be pretty unhappy if they leave without teeth. So I think a guide can be useful. I'm still at the camp of like a bone reduction portion. The number one mistake that dogs have failures with arches is because an inadequate bone reduction or having stable implants. So I think fully believe in working the case up on a CT, right? And if you want to use a lab, you can do that or do it yourself. If you really want to use a guide, then do a bone reduction guide, but throw that thing in the trash because I really believe that you have to give the patient teeth. And if you don't have that feel for the bone and the bone can feel like D1 and it's really D4 or vice versa, right? It can just vary so much. So that's why I really focus on things like biological drilling protocols, like drilling slower and feeling bone and all those things. And I just can't, I had a very hard time myself using a guide because I just never really fully understood the bone. And I felt like I would get a lot of implants that were 25 or 30 newt centimeters, right? We were getting like 45, 50 millimeter ones. I think the learning curve to use a guide in full arch surgery, I think is actually more difficult in my view than it would be to just not use one. So I think it could be a very good tool. But for me, I mean, I can do an arch in an hour now, right? A lot of guys can too, but I couldn't imagine going back to a guide at this point.
And just a
So
question for Dr. Briskie, because Corey's already addressed on how they can restore their case and access to restorability from a temp perspective. How would you then have someone freehanding it who's a newbie, restore it? Because sometimes in the beginning, when I was brand new, I'd finish the arch, I'd be tired, I'd be suturing, I'd be tired, I'd be like, I don't have the energy to convert this thing and have acrylic everywhere. Like this thing is going to be, it's hard. So, how would you kinda advise someone to restore the arch on that day?
So I think making something like a windowless denture, right? You can make these now 3D printed because we do everything digital except for the surgical, right? So you can make um, a windowless denture with a cutout on the palate, right? Where you have the palate, you have tabs that go through it, and then you have it somewhere to aim for your multi units. I think that's very helpful for doctors to see not only like the bone reduction, but like where the multi units should go in the process when you are freehanding it, right? But just having something to show you where the multi units are going, I think is very important.
Okay, and then still like the acrylic pickup type of thing, or would there be a different way of
Pickups, yeah, outdated at this point. I do think smart denture conversions are definitely becoming the norm, and especially new dents, new methods actually being popular right now too for how they're doing their smart denture equivalent type of pickup.
okay. Yeah, and Corey, I didn't mean to cut you off, so, what
no.
were you say?
So I think the other interesting thing is I think we've been focused right now on FP3 style restorations. I think in the last 2, 3 years now, we're seeing this big push for bone preservation and going to more FP1 style restorations. I think guided actually shines even harder on an FP1 style than it does on an FP3, especially if we're talking, if we're doing FP1, I'm assuming we're not edentulous because we probably preserve bone and soft tissue architecture. So now we're looking at these segmented guides where it's sorry, we'll take out, we'll do these extractions. Now we have tooth-borne guides, which are the most accurate. We can do scalloping guides. So if we're working, we need interproximal bone to generate papillas. I can plan this out in a way doing guided with prosthetics that I just can't possibly do freehand. I think it shines the hardest on the FP1.
Yeah, no, Corey's 100% on this one. So this is the only time I actually would use a guide in my own clinic is that because, and this is also why I charge 5K more for to do it. It is because now I actually have to spend the time to work with the lab to get my scallop guide, right? And place these implants fully guided because you actually do have to place for FP1s. I 100% believe you can't do them free-handed. I've tried several times, never got the best result. So that's the one, actually the one time I would use it. Actually, probably is I wouldn't place anything else guided. I wouldn't do zygomas guided. I wouldn't do categories guided. I wouldn't do um, any other cases besides an FP1.
Yeah, I think the push to FP1s is interesting, and so I was actually having this conversation with another doc last week about, they were talking about freehanding guided, sorry, hard freehanding, FP1s. And so the point was he could bone scallop it himself and all of the above. And I think that's true to some degree. You can like try to do it that way, but if you have to move a midline, like you can't bone scallop a midline change. Like if you can, it would just be a nightmare. I think you'd be sitting there all day kind of shaving and shaping. So I'm into full agreement. FP1s, I think having a guide on board. I'm assuming everyone's saying tooth supported guide. So you do like a sequential extraction technique and have it rest on the teeth and then, do your surgery, then, extract the teeth later. Is there a specific way, Corey, you like to do your FP1 guides in full arch?
So whenever we can do a sequential like that, that's always our go-to method. I think, like, kind of your point too, I think it's fascinating where if we kind of follow the fundamentals of surgery too, let's say we know we need 3 millimeters from gingival margin to plaque bone. Like we can have all this figured out before we touch the patient. Like, and then when you take those temps off and you have these pseudopapilla, like in between every tooth, it's just such a amazing thing that how far you can push that technology. FP1, obviously implant position and dispersion and amount, we tend to be a little bit different. Basically, this is why I like planning my own cases because I can sit there and actually be like, all right, what makes the most sense for the order I want to do this in? So it's never exactly the same. It's going to depend what teeth I'm going to be able to get the most support on the guide with. And then the nice thing is, we get 2 or 3 implants in. We can take a couple more teeth. We can use those previous implants as supports for the next guide. So there's so many ways to do this just to make this the predictable method. And I think now too, like I don't know what you guys, but like the vortex screw for the FP1 is my go-to. Uh, I think that screw with a digital design and a nicely printed FP1 restoration. And I still know a couple people that are doing cylinders on their FP1s, but they're just taking so much of that restorative space up with the cylinder. So now we're able to keep that very minimal. We're seeing less breakage on the temps, thus we're getting better, soft tissue response in the long term. Uh, it really is cool to see kind of that paradigm shift, I think, in the last couple of years.
Yeah. What's your take on 3-on-6 versus FP1? Uh, in terms of just like what would you offer for a final restoration? Is there a big difference, or is 3-on-6 just like, hey, it's just another way to consider doing it? And there's no superior version with segmented bridges versus a fixed full arch.
I like the 3-on-6 idea. If you can get the implants in the right position and they're biomechanically going to work, I think over the long term, I could see the advantage of that for repairability down the road. Right. So we think about what the patient cost is going to be upfront versus is the patient cost going to look like over the lifetime. I could tell you if I had the bone and I needed that treatment modality at this point, I would probably shoot for 3-on-6 for myself, if possible. And so whenever I can, we do. And then I even think back to when we were doing FP3s. My grandma probably won't watch this. I can tell you, like when we did her FP3, we were doing like thimble bars and individuals. So that way we had repairability down the road for that. I think when you have, and the patients seem to appreciate too, when we have that conversation chair side, like if they're a candidate for it, I'll talk to them about the advantages of it. I'm like, hey, look, this is going to help you out hopefully tremendously down the road with repair costs. Because I think that's one thing, at least when I see some offices I know of, they don't talk about the long-term cost for the patient and the long-term, what is this going to look like 10, 15, 20 years from now? So I do think it does make you look like you're truly giving that patient what's in their best interest, which is what I'm always shooting for.
My biggest beef with like the 3-on-6 stuff is the marketing aspect of it. Uh, and if you actually ask a 3-on-6 provider what percentage of cases are a 3-on-6, it's closer to like 20%. It's not a lot or most of the cases. It's a few, it's like a smaller proportion of the cases. So I guess part of the marketing I just don't like in terms of the messaging, telling all the patients, if you're removing bone, you're doing the wrong thing. I don't like that type of diverse language in our dentistry field. I think it's going to lead to a lot of issues with lawsuits and tricky items like that. So my only issue is uh, the how far separate something like that can make us at some
I
point.
think it's weird that I'm already seeing like the opposite pendulum now, where everything was FP3, and now I know dentists are like everything is FP1. And I was like, well, that doesn't seem possible either. I was like, well, why don't we just have like a rational like thought in our head and sit down and look at the case and say, all right, this case is a better FP3 case, right? They've got 4 teeth left and a little hump in the front, right? Let's do that as an FP3, right? You have plenty of bone left. Yes, great. FP1. Wow, you got gobs of bone, 3-on-6. Right? I don't think it's that hard to just be able to be like see the advantage of each treatment modality when it's the proper time to use it.
Yep, agreed.
I think this is a good place to end in terms of we talked about FP1s. We're all in agreement on how to approach that. I have like 10 different ways that we could talk about materials and softwares and prosthetics. And you mentioned immediately loading your single implants and all of that with the soft tissue architecture and emergent profiles you can get with how you teach singles. Um, but I definitely think we have something here for a future podcast. If we can get you back on, I know your schedule is crazy. You're probably teaching a course in Chicago right now.
Yeah, yeah, but for you guys, anytime.
Awesome. Awesome. Well, so if any of the listeners want to reach out to you, find out more about what you do, what's the best place to find you?
So I would check out implanttrainer.com. That kind of has our courses, what we're doing as far as that goes. Check out Instagram at Dr. Corey Raymond. That's probably the easiest way to get a hold of me now. And I'm always there. Shoot me a message. I'm happy to help out with anything. I think like you guys, I just want to see the profession progress in a way that's a better option for the patients and kind of bringing everybody together.
All right, everybody, Dr. Corey Raymond, thank you so much. And we're excited to see you in San Diego.
Sounds good, guys. Do some surfing. Let's go.